We're now going to look at Chapter 15, which is Understanding the Research Findings. And before we begin this lecture, I want you to pull off the handouts that I've posted and also retrieve the article, Give Me Some Sugar, the Diabetes Self-Management Activities of African American Primary Caregiving Grandmothers. I'm also going to talk a little bit about findings. I'm going to talk a little bit about the discussion section, and I'm going to talk more about the recommendations section in this lecture. Findings are the results, conclusions, interpretation, recommendations, generalizations, and implications for future research and nursing practice. It is generally presented in two major areas called the results and the discussion of the results. The results section focuses on the results or the statistical findings of a study, where the discussion section focuses on the remaining topics, and the researcher generally has wide leeway in this section. The results section is where quantitative data or numbers generated by the descriptive and inferential statistics tests are presented. The results section may also be called the statistical analyses, the data analyses, or the analysis. It should reflect the analysis of each research question and or hypothesis that was tested, and the test that they use to analyze the data should be identified. The results section tells us about the relevance or the usefulness of the findings. It'll talk about statistically significant findings and may even give us some information on unsupported hypotheses. If a hypothesis is not supported statistically, or it is only partially supported, the study still is relevant, because unsupported studies can be used to identify a limitation, problems with the study's validity, bias, or some weaknesses. And data from unsupported studies may suggest that current modes of practice or current theory in an area may not be supported and therefore should be re-examined and researched further. Now, there are a lot of tables and figures usually found in the results section, especially under analysis. And it should provide you with a snapshot or an easy way to interpret what was important in those findings. A role of the table is to report results in some detail that the investigator does not explore in the text. And a good table is one that meets the following criteria. It supplements and economizes the text. It has precise titles and headings and doesn't just repeat what they also put in their paragraphs. Now, in the discussion section, they usually talk about the limitations, besides looking at the findings, and recommendations that are made for practice and future research. It contains, as I said, discussions of the findings, the limitation, recommendations for practice, and recommendations for future research. It enables the research consumer to judge the validity of the interpretations drawn from the data and the general worth of the study. Now, the recommendations section talks about practice theory and future research, as I just said. The investigator's suggestions for the study's application to practice theory and further research should be: what contribution to nursing does this study make? What are the strengths, quality, and consistency of evidence provided by these findings? And does the evidence provided in the findings validate current practice or support the need for change in practice? Slide 8. Now, I know those first slides were kind of esoteric. So what I wanted to do was to take this study on African American grandmothers who are diabetic and their caregiving activities, and kind of go through a very abbreviated critique of this study and to show you how it all kind of comes together, which is what you're going to be using as pieces of your systematic review. Now, the topic of our article is they wanted to look at the determination of self-care management activities in African American primary caregiving grandmothers. Now, they did a review of the literature, and what they found was African American women over 55 experienced the most severe outcomes from diabetes, specifically type 2. That African Americans are poorer and may have multiple caregiving responsibilities. African American women accept these caregiving roles because either they have some addiction, HIV, or military deployment of their own children, making them responsible for their grandchildren. Caregiving of grandchildren is an increased risk for physical and mental health of these African American women and can negatively affect self-care activities when it comes to diabetes. And if the self-care is inadequate, medical care may be ineffective. Finally, African American with primary caregiving may have difficulty balancing caregiving and self-care. They also found a gap, which was no studies found that compared self-management of diabetic African American primary caregiving grandmothers after assuming the role of primary caregiver for their grandchildren was found. Now, the purpose of this study was twofold. It was to capture the diabetes self-management activities of African American primary caregiving before and after the initiation of caring for their grandchildren, and B, to compare the diabetic self-management activities of African American primary caregiving grandmothers to diabetic African American women who are not primary caregivers of their grandchildren. So you can see that if we look at those purposes, you come up that it is a comparative descriptive design. Now, there are two groups in this methodology, but they're looking at two different things. The one is they're going to take the first group, who are the primary caregivers of their grandchildren, and they're going to look at them before they took on the caregiving role and after they took on the caregiving role. And then they're going to look at group 1, which is the ones that are the caregivers, versus group 2, which are African American grandmas who don't have any caregiving responsibilities. Now, in this study, they did a power analysis. Now, remember, power analysis is so that they can figure out exactly how many people they needed in their sample. And the power analysis showed they needed between 60 and 128 participants. And they did this at an alpha level of 0.05. They got 68 people, but remember, this was a sample of convenience. Therefore, the findings can only be applied to the sample or to those people, maybe somebody that you know that's a grandmother who's diabetic, and she's African American, and she looks like these people. And they also got IRB approval. Yay for them. Now, their inclusion criteria was that they had to be African American female, that they had to be between the ages of 55 and 75. They have to report self-report a diagnosis of type 2 diabetes. They needed to reside in Arkansas. They needed to speak English, have an MMSE of at least 25, and be able to understand and provide informed consent. And they had exclusion criteria. Those people who couldn't be in this study were grandmas who were caregivers for anyone other than their own grandchildren, and if they had a hemoglobin variant disorder. Now, they had two measurement tools. One was to collect the demographics of age, financial status, education, housing status, health insurance, and length of caregiving. There was no reliability nor validity done on the demographics, but if you remember, that's not usually done. The second was a self-management activities questionnaire. This was created by the researcher, and they wanted to know the number of days of eating a healthy diet per week, the frequency of self-monitoring of blood glucoses per week, the number of days of exercise, at least 30 minutes per week, medication adherence, the number of foot exams that the person did per week, and the yearly eye exams. Now, they got a face validity done on this instrument that they created, but there was no reliability estimates reported. Now, I want you to look at Table 1, which is part of the analysis. This is the demographic characteristics, and they did a descriptive analysis, the percentages between caregiving and non-caregiving groups. They did equivalence testing on these groups and found only one statistically significant difference, and that is the 0.000 p-value, if you see in that third column. What that means is that caregivers were more likely to live in a house versus an apartment. There was no significant differences in age, finances, education, or health insurance because all those p-values are above 0.05. But remember, with the demographics, we don't want to see any significant differences. The group should be about the same on all different demographics so that we can't say that one of these is an extraneous variable wandering in and mucking up the study. Now, look at Table 2, which is the chart that looks at the difference in caregiving before and after taking responsibility for grandchildren. It gives you only a t-value from the t-test, but then puts an asterisk by the significant differences. There were two significant differences. One was healthy diet got worse after caregiving. Before caregiving, they had a healthy diet 5.03 days per week, and after it was 3.74. Self-monitoring of blood glucose got worse. There was 11.24 tests per week before the grandmas took on the role of caring for their grandchildren, and only 5.44 after. There were no other significant differences. And if you look down at the bottom, you'll see that the asterisks are p-values of less than 0.001. Now, Table 2 shows us the difference between caregivers and non-caregivers. Once again, the t-values that are significant have an asterisk. There were again two. Self-monitoring of blood glucose was worse for caregivers, 5.44 per week, versus 12.53 for non-caregivers. And the number of eye exams per year were lower for caregivers. There was no significant difference on all the other factors. Now we're going to look at the discussion section. Now remember, I told you at the very beginning of this that researchers have wide leeway on what they can say within the discussion section. And what you as the reader need to do is to be able to look at what they're saying in that discussion section and decide, do the statistics really back up what the researcher says? If we look at, under the discussion section, caregiver self-management activities, there are actually 3 references to the study that are backed up by the statistics. The first one is African American primary caregiving grandmothers with diabetes encountered more difficulty adhering to a healthy diet and performing self-monitoring of blood glucose after the initiation of caregiving. And yes, in Table 1, we saw that those were significant findings. They also said the number of self-monitoring of blood glucose tests was significantly decreased in the caregiving group after the initiation of caregiving to less than 1 test per day, which does not meet the ADA standards of monitoring blood glucose at least daily. And yes, this was also found in that table as a statistically significant difference. Finally, they said this study found no evidence to support that financial difficulties prevented the grandmothers from performing self-monitoring of blood glucose due to caregiving in this sample, which was true. They showed that there was no financial difference before and after starting to take care of their grandchildren. Now, if we look at self-management activities, caregiving versus non-caregiving, the first paragraph brings me to some pause. What they said was, diabetic African American primary caregiving grandmothers had more difficulty performing self-monitoring of blood glucose than diabetic African American women who were not caregivers, which may be the result of financial constraints due to caregiving responsibilities. That is a little bit inconsistent with the data, because remember, the data showed no difference in financial status. However, they made this statement that an additional finding consistent with the literature was that these caregivers had less visits to their healthcare provider for eye examinations than the non-caregiving group, which was supported in Table 3. Now, there are an awful lot of limitations to this study, which was brought up by the researchers themselves. The first one was that these people, the grandmas, were self-reported type 2 diabetics. They had no official diagnosis. And there was a recall bias, because what they asked them to do was to recall diabetic self-management practices in the 2 to 3 years prior to the data collection. I can't remember what I did a week ago, let alone 2 to 3 years ago. Also, the caregiver group's questionnaire was longer than the non-caregiver group due to questions regarding caregiver status and self-management activities before and after initiation of caregiving. It doesn't know if it was too lengthy and if that had any impact or not. Also, they said it's quite plausible that factors unrelated to caregiving impacted the caregiver's ability or motivation to perform diabetes self-care management. And finally, the participants were from counties in central Arkansas and may not be representative of a more rural areas in the state, and the instrument was not tested for reliability. So, how much faith do you put in the findings? Yet, they talk about implications for clinical practice. They said that Afro-American primary caregiving grandmas with diabetes can be at serious risk for complications of diabetes because of their inability to perform self-management activities. Well, that may be true. Healthcare providers must be diligent in educating this population on the importance of performing diabetes self-management activities so that they delay or prevent the diabetes complications. And then they went on to talk about that the foundation of diabetes self-management is a healthy diet and enough physical exercise, and the providers must provide or stress the importance of yearly eye examinations, which are all true. They also talked about implications for future research. A lot of this related to the limitations. Number one, they said that they recommended that the questionnaire be evaluated for reliability and validity and to further refine it, and that research is needed to determine what factors prevent this population from performing these tasks routinely. They also said future research may be directed toward discovering what factors influence when this population checks their blood glucose, how fatigue and time constraints play a role in their meal choices, or how the age of the grandchildren impacts the ability to perform diabetes self-management activities. So you can see when you jump from the abstract, you may read an introduction and then go right to the conclusions. You may miss a lot of what exactly is important in the articles that you're looking for to change practice. And now you know how to do it.